I'm Professor Amr Elhadidy, Professor of Cardiology and Critical Care Medicine, Cairo University. I am the Egyptian Society of Cardiology board member and also board member of the Egyptian Working Group of Intervention. Today we have an important topic, how to deal with acute coronary syndrome patients during COVID-19 pandemic. This slide shows a lot of numbers of coronaviruses since 1960, and with different coronaviruses till the new COVID-19 that appeared at the end of 2019. And this the dashboard that shows the distribution of COVID-19 all over the world. The total confirmed number till now is above 2,494,000, with a total this is 171,000 deaths. If you distribute the cases with different countries, you will see that the United States has 31% of the cases, about 792, followed by Spain, Italy, France, Germany, and United Kingdom. This is this article's recommendation from the Peking Union Medical College Hospital for the management of acute myocardial infarction during COVID-19 outbreak, and this was published in the European Society of Cardiology journal. If you look to this scheme, you will see how to manage suspected STEMI patients with potential risk of COVID-19 infection. If you look at a suspected case with STEMI with no alternative cause of ST segment elevation and the time is less than 12 hours from the last attack and no contraindication to thrombolytic therapy, so go for thrombolytic therapy in the ER. If you have any of that different, so you will go for the test for COVID-19 and then you decide where to go after confirming the diagnosis of COVID-19 infection. What about if you have a STEMI patient with confirmed COVID-19? You need strict isolation, which start immediately. Thrombolytic contraindication should be evaluated. If the patient with thrombolytic contraindication should be transferred to a local designated infectious medical institution immediately for further treatment. Other patients without thrombolytic contraindication should first start IV thrombolysis and then transfer to the local designated medical institution of infectious disease for further treatment. What about STEMI patients with suspected COVID-19? You need to know the diagnosis. COVID-19 defined as fever, respiratory symptoms, and or epidemiological linkage to other COVID-19 cases or areas with cluster transmission. The emergency should be protected strictly according to the standard of the fever clinic. Routine blood examination, CRP, CBC, pharyngeal swab, sputum specimen, blood sample for detection of novel coronavirus nucleic acid, and chest CT is very important to confirm the COVID-19 infection. Considering the fact that most medical centers do not have a professionally protected interventional catheterization room, so you need another room that you can work with the suspected COVID-19 patients. But not all the hospital has two rooms. For one room can be done for the infected COVID-19 STEMI patients, and the other room for non-COVID-19 patients. So the conflict time required for the novel coronavirus nucleic acid detection and early reperfusion for acute MI is very important. It's recommended to start emergency IV thrombolysis for a STEMI patient if COVID-19 cannot be excluded in a short time. The cardiologist should be contacted for the indication and contraindication, and myocardial reperfusion therapy should be initiated within 30 minutes. If COVID-19 was diagnosed after IV thrombolysis, the patient should be transferred to the designated infectious medical institution for further treatment. If COVID-19 and other infectious diseases were excluded after IV thrombolysis, so the patient could be transferred to the TCU, and remedial coronary intervention therapy or intensive medical treatment could be considered depending on the patient's coronary status. In special circumstances, if COVID-19 could be excluded by the expert group within less than an hour, the possibility of having COVID-19 was clinically small, so the cardiologist should evaluate the following two schemes. First, monitor closely, conduct emergency coronary intervention immediately after elimination of COVID-19. Number 2, proceed with the on-site thrombolysis. Make the treatment decision after comprehensive consideration of the benefit to risk ratio. And during thrombolysis, you need to review everything. You need to review the ECG, the echo, and the chest X-ray. And after thrombolysis, you check the recanalization status of the patient and perform chest CT immediately. What about STEMI patients with low-risk COVID-19, which are defined as no fever, no respiratory symptoms, obvious respiratory symptoms, and epidemiological exposure to other COVID-19 cases or area with cluster transmission? So you need to do routine blood examination, ECG, chest CT, myocardial injury biomarkers, and or bedside echo should be done immediately. Bedside chest radiography can be considered in some cases as an alternative to chest CT for patients who have difficulty to move or uncontrollable factors. If you have a specialist in infectious disease, you can consult urgently for the possibility of sending pharyngeal swab, sputum specimen, blood sample for further exclusion of novel coronavirus nucleic acid. If the infectious disease specialist considered it unnecessary to send this biological sample, so the patient should be transferred immediately to the cardiac cath lab for emergency coronary intervention or transferred to CCU after IV thrombolytic therapy. If after consultation of the infectious disease specialist and consider it indispensable to send the biological samples and the patient has no contraindication for thrombolytic therapy, so thrombolysis should be conducted immediately in the emergency room. The pharyngeal swab, sputum specimen, blood sample for the novel coronavirus detection should be sent after the start of thrombolytic therapy. And you need, after thrombolysis, what to do? You transfer to the designated, if you've confirmed, so you need to transfer your patient to designated infectious medical institution or CCU according to the result. If the patient had thrombolytic contraindication and the result of nucleic acid detection of COVID-19 should be waited for, and the patient excluded from COVID-19, you need to transfer the patient immediately to cath lab for emergency coronary intervention therapy. And the patient diagnosed with COVID-19, you need to transfer your patient to the specialized local designated medical institution for infectious disease. And this is the management of suspected unstable angina or non-STEMI patient with potential risk of COVID-19 infection. If you look to this diagram, if you have a suspected case, you need to have risk stratification according to the GRACE score. And if you have COVID-19 detection, screening is very important. If yes, you need this patient who's high risk non-STEMI, yes, you need to admit to the CCU and the coronary intervention, invasive intervention. If you have no potential risk of COVID-19, so you start the treatment, you need to do lab test for COVID infection. If no, you transfer the patient for designated, if it's positive COVID infection, you need to transfer. If not, you can continue the medical treatment in the CCU. What about acute infarction with non-STEMI patients? Thrombolytic therapy, you know, in non-STEMI patients has no clinical benefit. If you have a non-STEMI, you know you don't need no response for thrombolytic therapy. The treatment strategy should be based on the risk stratification of coronary artery disease, as we mentioned before. Therefore, it is necessary to evaluate the existence of COVID-19 as soon as possible. The treatment strategy should be based on GRACE risk stratification while waiting the result of novel coronavirus detection. If you have a confirmed with non-STEMI COVID-19 infection, you need to transfer to the designated medical institution immediately for further treatment. If you have a suspected non-STEMI patient and suspected or unable to be excluded from COVID-19, you need to consult the specialist, as we mentioned, for respiratory physician from designated medical institution to confirm COVID-19 as soon as possible and to do chest CT and the test for the coronavirus immediately for suspected case. If COVID-19 can be excluded by infectious disease specialists, according to the chest CT, it is recommended to choose a treatment strategy according to risk stratification, as we mentioned before, for non-STEMI ACS patients, intervention or medication. If COVID-19 cannot be excluded by chest CT, routine medical treatment of non-STEMI should be given and the risk stratification should be conducted while waiting the results of nucleic acid detection for the virus. For patients with low or moderate risk, routine medical therapy. We know the routine and wait and then do the follow-up for the detection of the patient and the stabilization of your patient. If the patient is high or extremely high risk patient, and especially those with hemodynamic instability or strong indication for immediate intervention treatment, the high-level infection control panel should be started. Two or more specialists should co-determine the risk of COVID-19. If the risk of COVID-19 is considered high, the patient should be transferred, as we mentioned before, to the local designated medical institution for intervention treatment and enhanced supportive treatment. For non-STEMI patients excluded from COVID-19, early or time-limited intervention strategy should be selected immediately according to the risk stratification of non-STEMI ACS patients. This is the EgSC recommendation and the consensus for those patients for intervention, cardiovascular angiography and intervention. And the areas discussed in document, most important to our topic is handling of emergent procedures, including STEMI and high-risk non-STEMI patients. The American College and the EgSC guidance, if you have a confirmed COVID-19 patients, although there are suggestions of thrombolysis first approach for STEMI patients from the Chinese experience, that was published before, the EgSC and EgSC Society suggested that it is appropriate with the current COVID-19 disease burden in the United States, in the presence of a STEMI or non-STEMI with ongoing ischemic symptoms, hemodynamic compromise, the patient should be taken to the cath lab for angiography primary PCI with the full protective equipment and the appropriate infectious disease protection for the entire cath lab team. Post-transfer patients who have received fibrinolysis should still be taken for rescue PCI if clinically appropriate. For non-STEMI patients who are otherwise stable, to minimize the risk of staph exposure, medical management with coronary angiography for the symptoms, and only if you have an abnormal or continuous chest pain or you need to the elective. If you have no severe chest pain and the patient is stable, you can do elective coronary angiography for, at a future time when the patient is less infectious. The possible COVID-19 patient, when these patients present with a STEMI, they should be treated with the primary PCI with appropriate infectious disease protection, as presently there is no widely available rapid test to exclude the diagnosis of COVID-19. When presenting with a non-STEMI, these patients should wait the coronary angiography until a negative COVID-19 test has been obtained. This diagram shows the STEMI patient after clinical and the EKG diagnosis, and the patient, if you have the COVID-19, yes, confirmed, you need to transthoracic echo to confirm more motion abnormalities, and then lytic therapy if failed to go for rescue PCI. If COVID-19 is not confirmed, so and is not in your patient, so you need to, with the full protection, you need to prepare the patient for the test and then go for primary PCI. If you have a non-STEMI patient, so this is the guideline, directed medical therapy. If you have hemodynamic instability, electrical instability, or ongoing evidence of ischemia, go for cath lab. If no, to continue medical treatment and then discharge and prepare your patient for elective coronary angiography when the general condition or the pandemic became less risky. This, the EgSC recommendation, finally, all STEMI patients should be rapidly screened by COVID in the emergency room, history, and clinical symptoms and presentation. And if you have a low prevalence of COVID in the general community, which is not now in the scenario, so the primary PCI remain the primary strategy. If you have a more prevalence of COVID as in the general population, as now we are seeing in the United States, you need to go lytic therapy as a first line treatment. As prevalence of COVID increase and system delay manifests, there may come a time when lytic therapy may have to be considered in a larger portion of patients. Thank you.